Hi everyone, this is videos about my day in life as a dietetic intern, working for my clinical rotation. This is the hospital that I was interning at, Valley Presbyterian Hospital located in the greater Los Angeles area. With 350 beds and specialized in cardiac care, orthopedics, and critical care services. This is a typical day for me as an intern, and I hope by my vlog I can explain or show you more about what you would expect as working as a clinical dietitian. Unfortunately, I wasn't able to shoot inside the hospital or when I was doing nutrition counseling with my patients due to HIPPA violation. Therefore, most of the shots will be in the RD office. In this video, I might use the term RDNs a lot, and that stands for Registered Dietitians Nutritionist. This is the RDN's office. And at the left side, that's the Diet Assistant's office. Diet assistants mainly help to take the food order for the patients and help the dietitians to do calorie counts if there's needs for one. This is the Cardex folder, aka patient profile card, organized by floors. Cardex acts like a quick notes for the RDN to write or record the basic information for the patients. The first thing that I will do in the day is to screen the floor and assign the nutrition risk levels for newly admitted patients. This is required by the hospital's policy. The specific requirements might be varied by different hospitals, but every hospital shall have this process to allow dietitians to assess nutrition risk for their patients. The registered dietitians will use their clinical judgment to decide what level of risk will this patient be. If a patient has a high nutrition risk, for example, who has gastrointestinal obstruction or who's on tube feeding, parenteral nutrition, aka IV nutrition, or who has severe malnutrition, the RDs will see this patient within 3 days. Basically, the high-risk patients on the RDN's standpoint are patients that could not get nutrition properly. In many cases, these situations happened for a while due to their disease status. If the RDN thinks the patient have moderate nutrition risk, then the patients might have issues like acute kidney injuries, sepsis, or diabetes. These patients might have complex medical and nutritional status, but they are likely still be able to tolerate foods or another nutrition supplements. Therefore, they're not the most urgent cases for dietitians, and we will assign this patient as a moderate risk case and see him or her within 5 days. For low-risk patients, there are patients that dietitians can't do much to help on nutritionally. For example, who has bone fracture. This will consider low nutritional risk for us because the patients can still eat, and the only thing that a dietitian can do is probably to increase the calorie needs for healing. These patients probably require surgery or something else, but that is not in the control of the dietitians. In this case, for a low-risk patient, we will likely to see the patients within a week. However, the risk levels were only a guideline. You will still need the patient's whole picture to assign the patient's risk level. For example, if this patient has bone fracture, but he's older or he has other medical complications, this will easily bring these patients to a moderate or high risk. After that, I will check the Cardex to see if any patients has been transferred to other floor or discharged from the hospital, so I can also rearrange the Cardex for my floor. After recognizing the Cardex, I will print out a list of patients that I will go visit for the day and get their Cardex. If there's a new patient, I will start with a new Cardex and be ready to write on it. This is how the Cardex or the patient's profile card look like at my hospital. It has patient's basic information like name and age. It also has the diet order for the patients in different dates. When we flip through, there are spaces to write and keep track of the patient's lab values, weight changes, and medical history. At the back, this is for the RDN to write their notes for the patients. After screening the floor, assigning risk level, and finalizing the patients that I will be visiting today, I always get a coffee break with my preceptor. Get our coffee.
Oh, video? Oh, okay. Yes, let's go.
After our short coffee break, we are back to the office. What I'm doing now is to read the medical charts for the patients that I will be visiting today. I will gather as much as information from the physician's notes, the nurse's notes, the speech therapist's notes, and any other healthcare professional's notes that could provide me the information I need. I will write the info on the cardex. Usually, I will read the patient's past medical history, current disease status, reason for admissions, lab values, weight changes, intake and outputs, and if the patient has any pressure ulcers. After writing down all the useful information, I have a more complete picture of the patient. RDNs will also need to calculate the calorie need, protein need, and fluid need for the patient. It has different requirements for calorie need for different diseases because some diseases require higher calories, while some diseases require lower protein intake. If the patient is on or will be starting tube feeding or parental nutrition, I will also need to calculate the rates of feeding, calories, and proteins from the feeding. If this is a follow-up patient, I will read the previous RDN's notes as well. After gathering all the information I need and write on the cardex, it's now time to go to see my patient. I will also bring educational material, cardex, sticky notes, pen, a translator phone with me when I go to the floor. When I come back to the office, I will start to work on the patient's chart. I will type it in on Meditech. Once a chart or a document is uploaded to Meditech, other healthcare professionals at the hospital will have access to it. This is a blank chart from Meditech. The chart included everything of the patients, including nutrition history or risk, history of vitamins, mineral, or herb intake, estimated energy needs, muscle wasting, tube feeding formula, rate of feeding if applicable, total parental nutrition order, rates and calories provided, lab values, medication, nutrition assessment, and the plan for the next step. After seeing all the patients you have for the day, this is about it for your day. If you have a light day today, you could also choose to work ahead to do nutrition assessment for patients that you will need to visit for the next day. That's about it for a day in life as a dietetic intern or a clinical dietitian. I want to end this video with our Rdn Day Celebration Lunch. I'm really grateful that the RDN credential is recognized by more and more people. I know that there are a lot of amazing RDN out there working to promote health and nutrition to the population. Last but not least, I want to say a big thank you to all my preceptors at VPH. I feel so lucky to be able to work with you all. You all are the greatest preceptors. Thank you for explaining different clinical conditions with me, being so patient with me, giving me the flexibility to work on patients that I'm interested in, and teaching me to become a successful RDN in every way. Thank you all for also watching my videos. I hope you see what a clinical dietitian's life or a dietetic intern's life at a clinical settings looks like. If you like my video, please subscribe, give me a like. That will really help me a lot. And I will see you in another episode. Bye!